Hey there, I'm Dr. Stuart Ackerman. It's been a little while since I've published a video blog, but I wanted to take this opportunity to discuss a recent article that was published in the New England Journal of Medicine that's been getting a bit of press. It talks about screening colonoscopy for colon cancer screening. But before I discuss my thoughts on the study, I wanted to take a few minutes to discuss research in the medical field in general and how it gets published and the standardization process when it comes to that research. So, when a study gets published, there is a fairly standardized way that a medical journal will publish that study. It gets published in two parts. There's the kind of cover page, which is called the abstract, and that's a summary of the findings of the study and the quick conclusion or discussion of those findings by the investigator and authors. And then there's the larger kind of meatier part of the study, which discusses everything that they talked about in the abstract in detail. You can kind of think of the abstract as the cover of the story, which is the study itself. The publishing of a study, or I should say the publishing of an abstract, is done in a fairly standardized process. There are four parts to the abstract. So if you pick up an abstract from any medical journal, it should follow, for the most part, the same flow. It starts out first with a background or an objective. What are we looking for? Where are we coming with this question that we want to answer? The second portion of the abstract is the methods. That's kind of the nitty gritty. How did we do this study? That's followed by the results, which is somewhat of a black and white retelling of what was found in the study. And then the last part is the conclusion. What does the author feel that the results, or how does the author interpret the results? In the actual major portion of the study, you'll find more of a discussion explaining why the author interpreted those results in the way that they chose in order to get to the conclusion based on those findings. So, understanding that, it's really important that when you critically appraise a research study, you don't only look at the abstract because there may be pieces of information that are missing for you to make a logical or an educated conclusion. And you might, in fact, read this and interpret those results differently than the author. Often, this is similar. The example we give is politics. There could be an event that occurs, and two different sides see that same event and interpret it in different ways. It doesn't mean that one is right or wrong. It's just a different way to interpret the same series of facts. So in this study, the authors looked at two populations. This was done in 4 countries in Europe, and they had a total of 85,000 patients in the study. And in one arm, those were patients that were not invited to do anything. They didn't perform any kind of screening for colon cancer. And then in the other arm of the study, they had patients that they invited to get a colon cancer screening with a colonoscopy. And as I mentioned a minute ago, there were about 85,000 patients that were included in the study. And of those 85,000 patients, 28,000 were invited to be included and to get a colonoscopy, and only a little under 12,000 of those. So now you're saying 12,000 of the total 85,000 actually underwent a colonoscopy for screening and had it done. And of these patients that had it done, about 30% of them were found to have colon polyps that were removed. And I should mention, this was done over a 5-year period between 2009 and 2014. And then some of the patients were followed out up to 10 years to see in both arms who developed colon cancer in the interim. And what they found was that in the group of patients who had a colonoscopy, 259 cases of colon cancer were diagnosed, as opposed to 622 cases in the group of patients who were not invited and didn't undergo any kind of screening. And therefore, the conclusion that was reached by the authors was that at 10 years out, it didn't have a significant impact inviting patients and undergoing colon cancer screening with colonoscopy than compared to those that didn't do anything. And this is why this has garnered such interest and discussion because, as you may or may not be aware, here in America, we're very aggressive with colon cancer screening. We actually try to get patients to come in starting at age 45 who don't have any kind of risk factors. And certainly patients that have risk factors like a family history, we try to get to come in even earlier because we found that, in fact, there's a significant reduction in the incidence of colon cancer. And by increasing those rates year over year, we've seen a decline in the overall incidence of colon cancer. So, how does that make sense in light of this fairly large study? So, when you read through the study a little more and you look at the way they analyze the data, the authors chose to analyze the invited group data altogether. So when they analyzed the number of polyps, when they analyzed the interval cancers, they did that for all the patients who were invited into the study as colonoscopy patients. However, when I look at that, I don't see that as a fair metric because you can only truly evaluate those people who underwent an intervention. Is there really any difference between someone who was invited and didn't undergo a colonoscopy versus someone who wasn't invited as far as their risk of development of colon cancer? Contrast that to the patients that did get colonoscopy and therefore potentially would have benefited from that decline. So that's one big issue because it does skew what those numbers show. The other issue I have when I read this is this study was done in countries that might not have robust screening protocols like we have. The fact that a significant portion, more than half, weren't even invited to do any kind of screening is not something that's really the standard of care here in America. So it's a little bit difficult to read a study like this and try to make it make sense and relatable back to our own patient population. It might be something that doesn't quite apply, and if it were reproduced in an area like where I am in Texas, where people are much more motivated and I would say educated really about screenings in general, that they might be more motivated. So, on the one hand, of the people invited, we may have seen a much higher uptake in those undergoing colonoscopy. And also, I don't know that we would have had a group of patients who would have been okay being randomized to not doing anything at all. The third point that I think is really important to take into consideration when trying to interpret these results is the median follow-up was only 10 years. This in itself might be a bias because 10 years may simply not be a long enough time to notice if you've had a long-term benefit from the screening procedure. The reason for this is that it takes time. A polyp evolves into a cancer, and that doesn't happen in a short period. The reason why we recommend that a patient who's average risk and gets a colonoscopy and has a negative exam should repeat their exam in 10 years is because we know we've missed some small polyps. It's just part of the risk of the exam that we're not perfect. So if we assume we missed a small polyp, and given the natural history, we assume that it'll start growing and evolving over time. If that patient comes back in 10 years, we don't expect that they'll have a cancer. We expect that there'll be a large polyp that we'll find easily and remove, still preventing it from becoming a cancer. So, to say it a different way, if we don't catch a polyp today, we likely don't expect that it'll be a cancer for 12 years or 15 years. So if we checked that same patient at 10 years, we don't have much of an expectation to see cancer. So the fact that they described in their study a follow-up of 10 years and therefore found that there wasn't much difference between those that had the colonoscopies and those that didn't may be explainable by the fact that they simply didn't wait long enough to follow up the patients. Maybe if they waited 15 years or 20 years, you'd see the two lines diverge. And those that did get colonoscopy and had polyps removed may have been found to have a significant benefit in comparison to the patients that had nothing done. I hope that makes sense. If there's any questions about this, I welcome comments. Please feel free to comment below. If you'd like to discuss this further, if you'd like to get your own colonoscopy, please feel free to navigate over to my website, click on the appointments page, submit your information, and one of my staff members would love to get back to you in the near future.